Hello, everyone. My name is William Kirsch. I'm a PGY1 pharmacy practice resident from UTMC, and today I'm going to be discussing status epilepticus with a focus on the pharmacological management. So first, I'd like to begin with my learning objectives. At the end of this presentation is my hope that you'll be able to summarize the Neurocritical Care Society, or NCS, guideline recommendations for the evaluation and management of patients with status epilepticus, and then apply evidence-based medicine to a patient presenting with status epilepticus. From here on out, I will refer to status epilepticus as SE. To provide you with an outline of the presentation, I will first introduce the SE patient case, provide some background on SE, review the SE guideline recommendations, and then return to the patient case and discuss the therapy options. So looking first at the patient case, JR is a 26-year-old female who presents to UTMC's ED via EMS for recurrent generalized tonic-clonic seizures. They have been ongoing for the past 25 minutes, and she's had multiple seizures without return of baseline. She has no known drug allergies. Past medical history is listed there, and her home meds include levetiracetam, 1,500 milligrams, PO twice daily, and then sertraline, 150 milligrams daily. The following are some general questions related to the patient case that I'd like you to think about during the presentation. What emergent initial therapy should be initiated? When should control therapy with longer-acting medications be started? And if the patient is refractory to first and second-line agents, what can be tried next? Next, I'm going to refresh your memory with some background on the SE. So the current definition of SE is greater than or equal to 5 minutes of one of the following: continuous clinical and/or electrographic seizure activity, or recurrent seizure activity without recovery between seizures, recovery meaning return to baseline. Previous definitions of SE were defined as greater than 30 minutes of continuous seizure activity, or greater than or equal to 2 seizures without recovery between seizures. However, permanent neural damage may occur before 30 minutes has passed, and most seizures that last longer than 5 minutes do not cease spontaneously, and this is where the new definition came in. NCS divides status epilepticus into 3 different classifications: generalized convulsive, or GCSE, non-convulsive, or NCSE, and refractory, or RSE. Generalized convulsive is characterized by convulsions associated with rhythmic jerking of extremities, whereas non-convulsive is opposite, where it's seizure activity seen on the EEG without clinical findings of GCSE. Some negative symptoms and positive symptoms associated with non-convulsive are listed there. And both GCSE and NCSE can become refractory. So these are patients who do not respond to standard treatment regimens for SE, and they continue to experience clinical or electrographic seizures following receipt of adequate doses of initial benzodiazepine and adequate doses of a second anti-epileptic drug, or AED. Most experts do not consider duration of SE to be a criterion for classification of refractory anymore. So it's only based on whether they got adequate doses of the first 2 AED medications. Focusing next on the epidemiology, around 5% of adults with epilepsy will have at least one episode of SE during their lifetime. Incidence ranges from 10 to 41 cases per 100,000 people per year. And as far as morbidity, it may result in severe neurological or cognitive sequelae and deterioration in functional status, mostly associated with GCSE. Around 13% of SE patients will have a recurrent episode. And in patients with no history of seizures, about 20 to 40% with a single episode of SE will develop epilepsy. Overall mortality is generally about 20%, but has ranged from the percentages listed there at hospital discharge in previous studies. Some factors associated with a higher mortality rate include the elderly, patients who present with acute stroke, anoxia, trauma, infections, or metabolic disturbances. A lower mortality rate is associated with patients who have a previous stroke versus coming in with an acute stroke. alcohol or anticonvulsant withdrawal, tumors, or epilepsy. Listed here are some potential causes associated with the development of SE. Some acute processes include metabolic disturbances such as electrolyte abnormalities, hypoglycemia, and renal failure, CNS infections including meningitis and encephalitis, stroke, head trauma, drug toxicity, drug withdrawal, non-adherence with AEDs, hypoxia, to name a few, and then chronic processes such as pre-existing epilepsy, chronic alcohol abuse in the setting of ethanol intoxication or withdrawal, CNS tumors, and then remote CNS pathology such as a previous traumatic brain injury, stroke, abscess, or cortical dysplasia. SE is likely due to the failure of endogenous mechanisms that prevent or terminate sustained seizure activity. Ongoing seizures potentially cause a decrease in GABA A receptors, which are the main inhibitory receptor of the body, and an increase in NMDA receptors, which are the main excitatory receptor in the body. So the number of GABA receptors are reduced at the synaptic membrane by transport into endosomes and then are degraded by lysosomes or recycled by the Golgi apparatus, leaving the neurotransmitter unable to reach the GABA receptor, which is shown in the top right-hand corner of the diagram. On the other hand, in the bottom of the diagram, the number of NMDA receptors are increased at the synaptic membrane by assembly of additional receptors. So in summary, the number of functional GABA A receptors per synapse decreases, and the number of functional NMDA receptors per synapse increases, leading to reduced inhibition and increased excitation. The following are the suggested diagnostic workup that should occur as soon as possible and at the same time as treatment. In all patients, it's recommended that you obtain a finger stick glucose, monitor vital signs, obtain a head CT in most cases, and then some labs that you should obtain are CBC, BMP, total and ionized calcium, magnesium, and the AED levels if the patient was on an AED at home. And then you also want to institute continuous EEG monitoring. Some other workup that you may consider based on clinical presentation includes a brain MRI, a lumbar puncture if you are considering it to be infectious, a comprehensive toxicology panel focusing on toxins or medications that may cause seizures such as TCAs, cocaine, and alcohol. And additional labs you also may consider include LFTs, serial troponins, type and hold coagulation studies, and arterial blood gases. Besides epilepsy being the most common complication following an initial episode of SE, some other complications of convulsive SE include cerebral, such as cerebral edema or cerebral infarction, cardiorespiratory, such as cardiac arrest, cardiac shock, respiratory failure, and pulmonary edema, and metabolic or systemic complications such as electrolyte disturbances, DIC, rhabdomyolysis, and acute renal failure. Now that you are familiar with the background of SE, I'm going to transition over to the SE guideline recommendations for treatment. The initial management should be done in an emergency department or in a critical care environment and follows the basic life support principles. So you want to assess airway. So an oral or nasopharyngeal device or bag mask ventilation is usually adequate to maintain oxygenation and prevent hypoxemia. Intubation may eventually be required in prolonged seizures or after large doses of sedative medications are given. You may need a neuromuscular blockade to perform an GCSE because of the convulsions. In this case, the drug of choice is rocuronium because it is short-acting and due to the risk of hyperkalemic-induced cardiac arrhythmias if succinylcholine is given in the event of the patient presenting with rhabdomyolysis. You want to obtain peripheral or central IV access for drugs and fluid and nutrient resuscitation, and you should consider giving thiamine in patients who may be deficient. And you also want to have the continuous pulse oximetry, ECG, and EEG monitoring of blood pressure and urinary output. And similar to the principles in cardiac arrest, you wanted to do aggressive cooling and hyperthermia as uncontrolled hyperthermia increases neuronal damage. The following is a general timeline from the point of seizure onset that should be followed when administering medications for an SE patient. Emergent therapy should be initiated within 5 minutes of seizure onset, and it may be administered by EMS prior to presentation in the ED. Urgent control therapy should be initiated within 5 to 10 minutes of seizure onset, and refractory therapy should be instituted within 20 to 60 minutes after seizure onset. And I'm going to elaborate on each of these components in the next several slides. Although many different classes of AEDs have been studied for use in emergent initial therapy, benzodiazepines or BCDs remain the agent of choice based on supporting evidence and expert opinion. These medications have a direct action on the GABA-A receptors and thus have an inhibitory effect on neuronal excitability. So the IV drug of choice is lorazepam, the IM drug of choice is midazolam, and the rectal drug of choice is diazepam. The IV route is preferred, so diazepam rectal is recommended only when there is no IV access, and IM midazolam is contraindicated. Less preferred options include fosphenytoin or phenytoin, phenobarbital, valproate, and levetiracetam. There are an inadequate number of randomized controlled trials to recommend optimal dosing, so the following doses are based strictly on observational data and expert opinion. Lorazepam is dosed 0.1 milligrams per kilogram IV push, up to 4 milligrams per dose, and it may be repeated in 5 to 10 minutes. Adverse effects of all these agents include respiratory depression and hypotension. Some clinical pros with lorazepam is that you want to dilute 1:1 with saline, and the IV version contains propylene glycol, so it may be associated with lactic acidosis with prolonged use or in high doses, but this is usually associated with continuous infusions. Midazolam, on the other hand, is dosed 0.2 milligrams per kilogram IM, up to a maximum of 10 milligrams. And some clinical pros are that it has rapid redistribution, so short acting, has an active metabolite, and it is renally eliminated. Diazepam is dosed 0.2 milligrams per kilogram rectally. It also has a rapid redistribution. It has an active metabolite, and the IV version contains propylene glycol. Please note that doses should be titrated based on clinical and EEG findings, so what is used in clinical practice may be higher than what is shown here. Urgent control therapy should be initiated in all SE patients unless the immediate cause of the seizures was known and corrected, such as hypoglycemia. The two main goals of urgent control therapy are to maintain seizure cessation by rapid attainment of therapeutic AED levels with continued maintenance dosing in patients who responded to emergent therapy, or to achieve seizure cessation in emergent therapy non-responders. Conflicting data and differences in expert opinion for what agent is best for control therapy, and it's usually based on individual patient circumstances. So you may consider an IV bolus of an outpatient AED in patients with known epilepsy, and you may need to obtain higher than normal target concentrations in order to achieve seizure cessation. Listed here are the medications recommended for urgent control therapy and decreasing class and level of evidence behind the recommendation. Valproate is preferred in patients with a history of primary generalized epilepsy, whereas fosphenytoin is preferred for most patients without a history of primary generalized epilepsy. And the other three remaining recommended options for urgent control therapy are midazolam, phenobarbital, and levetiracetam. And IV administration is required for all of these agents in order to achieve therapeutic levels rapidly. Valproate is dosed 20 to 40 milligrams per kilogram IV, and you may give an additional dose 10 minutes after the loading infusion. Adverse effects include hyperammonemia, pancreatitis, thrombocytopenia, and hepatotoxicity. And you want to use them with caution in patients with a traumatic head injury because a study in the past showed increased mortality compared to phenytoin in these patients. Fosphenytoin is dosed 20 milligrams phenytoin equivalents per kilogram IV, and you may give an additional dose 10 minutes after the loading infusion, whereas phenytoin is dosed 20 milligrams per kilogram IV, but only at a rate up to 50 milligrams per minute. whereas phosphonatoin can be given up to 150 milligrams phosphonatoin equivalents per minute. And you may also give an additional phenytoin dose 10 minutes after loading infusion. Adverse effects of these medications include hypotension, arrhythmias, and purple glove syndrome. So purple glove syndrome is discoloration and pain at a peripheral IV site. To avoid this, you want to inject slowly into a large vein and flush with normal saline. And there is a lower risk with phosphonatoin. So something I wanted to note is that phenytoin IV is automatically substituted to phosphonatoin at our institution, so it can be administered more rapidly. Some clinical pearls for phosphonatoin is that it is compatible in saline, dextrose, and lactated Ringer solutions, whereas phenytoin is only compatible in saline, and the phenytoin IV contains propylene glycol. Midazolam is dosed 0.2 milligrams per kilogram IV at a rate up to 2 milligrams per minute, followed by a continuous infusion of 0.05 to 2 milligrams per kilogram per hour. Again, adverse effects include respiratory depression and hypotension. And something I wanted to note with the continuous infusion is that tachyphylaxis can develop after prolonged use, so you will need higher and higher doses to attain the same therapeutic effect the longer the patient is on it. Phenobarbital is dosed 20 milligrams per kilogram IV, and you may give an additional dose 10 minutes after loading infusion. And in the IV version of phenobarbital, it does contain propylene glycol. And lastly, levetiracetam is dosed 1,000 to 3,000 milligrams IV at a rate up to 2 to 5 milligrams per kilogram per minute. There are usually no severe acute adverse effects associated with this medication, and it does have minimal drug interactions and it is not hepatically metabolized. Some common causes of treatment failure following initial management and urgent control therapy include underdosing initial emergent therapy. So you can develop progressive pharmacological resistance to meds the longer seizures progress. Again, GABA-A receptors decrease at the synapse the longer the seizures occur, and there's evidence that other isoforms of the receptor may develop. This means that if seizures continue, larger and larger doses of the medications will likely be required, increasing the risk of the patient. Some other common causes include not starting urgent control or maintenance therapy, which may cause a relapse in SE once the benzodiazepines wear off, and then a misdiagnosis at the presentation, and then failure to diagnose and treat underlying etiology of the SE or the secondary complications. If SE persists clinically and or on continuous EEG monitoring after both emergent initial and urgent control therapies have been tried, the patient is considered to have refractory SE. Some options at this point include to repeat the bolus of an urgent control AED or immediately initiate alternative agents. Either way, additional treatment should be initiated immediately. There's no data to suggest waiting is safer than instituting aggressive therapy. It's recommended that you initiate a continuous infusion AED and refractory therapy, and the specific medication depends on the patient's underlying condition. The following medications are the ones most often recommended for use as a continuous infusion. There's currently insufficient data to suggest one medication over the other, but listed under each medication are some considerations that you want to think about when giving to patients. So midazolam does cause less hypotension. Propofol may cause propofol infusion syndrome with long durations of infusions at high doses. And pentobarbital does have a higher rate of controlling RSE acutely than midazolam, but it does have more severe adverse effects. And it is a very costly medication, so it would likely be best to consider other agents before resorting to pentobarb. Repeat bolus doses of continuous infusion AEDs can be given for breakthrough SE, and you may switch to a different continuous infusion or start another agent if the AED chosen for RSE fails. The dosing for midazolam is provided there. It's the same as for urgent control therapy when using for the continuous infusion. Propofol is dosed 1 to 2 milligrams per kilogram IV, up to 20 mics per kilogram per minute, followed by a continuous infusion of 30 to 200 micrograms per kilogram per minute. Adverse effects of propofol include respiratory depression, hypotension, especially of loading doses in critically ill patients, cardiac failure, rhabdomyolysis, metabolic acidosis, and renal failure. You want to use caution when administering high doses for an extended period of time, since this does increase the risk of propofol infusion syndrome, which is a side effect characterized by dysrhythmia, hyperkalemia, and renal failure, and is associated with a high mortality rate. You also obviously need mechanical ventilation for propofol, and you must adjust the daily caloric intake since it is contained within a lipid solution. Pentobarbital is dosed 5 to 25 milligrams per kilogram IV, followed by a continuous infusion of 0.5 to 5 milligrams per kilogram per hour. It does cause respiratory depression, hypotension, cardiac depression, paralytic ileus, and it can cause complete loss of neurological function at high doses. Pentobarb also requires mechanical ventilation, and the IV version contains propylene glycol. Some goals of refractory therapy are to titrate to cessation of electrographic seizures or burst suppression, and to have 24 to 48 hours of electrographic control prior to slow withdrawal of the continuous infusion AEDs for RSE. It's important to sustain therapeutic levels of maintenance AEDs during the weaning period of the medication for RSE and to monitor the EEG continuously. Patients may have recurrent SE when withdrawing the continuous infusion, which will require a return to the prior or even higher doses of the RSE treatment for an additional period of time. The cumulative duration of continuous infusions does not appear to affect prognosis. RSE may be treated for weeks to months and still result in a full functional recovery. So you can continue aggressive therapy until therapy is deemed successful or futile. Prolonged therapy is usually more appropriate for young patients with a healthy premorbid state, self-limited disease processes, and an absence of intracranial lesions suggesting a poor prognosis. So listed here are some take-home points that I wanted to get across in my presentation. Emergent initial therapy should be instituted within 5 minutes following seizure onset. First line is benzodiazepines with IV lorazepam preferred. Urgent control therapy should be initiated within 5 to 10 minutes after seizure onset. Valproate sodium or phosphonate-1 IV bolus is preferred depending on whether or not the patient had a history of generalized epilepsy. And you can consider giving an IV bolus of their outpatient maintenance therapy before trying other agents. And then refractory should be instituted within 20 to 60 minutes following seizure onset. Midazolam, propofol, or pentobarbital continuous infusions are recommended, and the preference among these medications is based on the patient's current clinical condition. So lastly, I'm going to return to the patient case and discuss potential therapy options. So JR is a 26-year-old female who presents to UTMC's ED via EMS for recurrent generalized tonic-clonic seizures. She does have a past medical history of generalized epilepsy. And her home meds include levetiracetam 1500 milligrams PO twice daily, and then sertraline 150 milligrams PO daily. So she was diagnosed with status. So this takes me to my first question. So no EDs were given by EMS. Peripheral IV line placement was unsuccessful in the ED. So what emergent initial therapy is indicated in this patient? A, lorazepam PO, B, midazolam IM, C, diazepam rectal, or D, phenobarbital IM. So the correct answer is B, as midazolam is preferred if lorazepam cannot be given IV. Clinical seizure activity resolved following the dose of midazolam and a peripheral IV line was placed. What urgent control therapy is best to consider in this patient? A valproate IV bolus, B. Phosphonatoin IV bolus, C. Levetiracetam IV bolus, or D. No control therapy is indicated. The correct answer would be either A or C, since the patient is receiving levetiracetam as maintenance therapy at home. It would be reasonable to give a bolus dose of this prior to moving on to other agents. Valproate would be another appropriate option, since it is preferred in patients who have a history of generalized epilepsy. Electrographic seizure activity continued following IV bolus doses of levetiracetam and valproate. They are now considered refractory. The patient became severely hypotensive following initial therapies, and they are not currently intubated. What therapy is most appropriate to initiate in this patient? A. Midazolam continuous infusion. B. Propofol continuous infusion. C. Pentobarbital continuous infusion. Or D. Ketamine continuous infusion. The correct answer is A, as midazolam will have less effects on blood pressure and is less likely to require intubation. With that, I now conclude my presentation. So thank you for listening to this presentation. And if you have any questions, feel free to email me and reach out. Thank you very much.